Let us first go through the history of cardiac stress testing. Angina or chest pain was first described by Hebenden in 20 patients who suffered from a painful and most disagreeable sensation in the breast. Such patients, he wrote, are seized while they are walking, and more specifically, if it would be uphill and soon after eating. But the moment they stand still, all this uneasiness vanishes. The basis of modern stress testing was due to the recognition of the ST segment changes. ST segment in ECG represents the interval between ventricular depolarization and repolarization. The mechanism of the pain in angina pectoralis or chest pain has been the subject of speculation and investigation since the original report of this clinical condition by Hebenden. The electrocardiographic studies made during transient attacks of angina were reported by several observers such as Boesfield and Fail plus Siegel. Arthur Master introduced the Master Steps test, which is a standardized test used to assess cardiac function, particularly by taking ECG before and after exercise. Goldhamer and Scherf were the first to suggest the use of exercise ECG for the diagnosis of coronary artery disease in 1932. Exercise testing first appeared in the medical literature in 1938, which was introduced by Maurice Misal through climbing of stairs. To continue with the history, Reisman supported the study of Boesfield through ST segment depression. Jaffe stressed on the sensitivity of post-exercise electrocardiogram compared with the Master's two-step test. The Harvard STEP test is a test used to measure endurance. This test was developed during the Second World War by Johnson and Buhiha. The Harvard STEP test is a type of cardiac stress test for detecting and diagnosing cardiovascular disease. Wood compared the Master's two-step test with maximal exercise of Misal and found out 88% sensitivity rate in maximal exercise compared with 39% sensitivity in Master's step test in the diagnosis of coronary artery diseases. Exercise stress testing for cardiac patients has been in use for nearly 50 years. You introduce maximal treadmill protocol to predict or to screen coronary artery disease cases. The Astran test is a submaximal cycle ergonometer aerobic fitness test based on the relationship between heart rate during work and percentage of maximal aerobic capacity and was introduced in 1954. In 1956, Robert Bruce implemented an exercise protocol useful to functionally classify subjects according to New York Heart Association criteria. This protocol initiated the contemporary era of exercise testing, and many of the stress test protocols currently utilized for diagnostic as well as prognostic purpose are based on modifications of those described by Bruce. From the late 1970s, the application of Bayesian analysis to exercise stress tests contributed significantly to improve the accuracy of the test, and now many guidelines rely on the pre-test likelihood of coronary artery disease to select more appropriate diagnostic tests. Now, with the development of the radionuclide techniques that permit imaging the myocardium of the left ventricular blood pool at rest and most importantly during exercise, exercise stress tests entered a new era but significantly increased costs and introduced a radiation burden. Cardiac stress testing is a means to diagnose coronary artery disease in the presence of anginal symptoms and is important in evaluating patients with symptoms of chest pain. Stress can be induced on the heart in one of two ways. First is the exercise stress testing, and the other one is the drug-induced, known as the pharmacologic stress testing. The doctor may recommend a test with imaging, such as the nuclear stress test or echocardiographic stress test, if an exercise stress test doesn't pinpoint the cause of the symptoms. Let us talk about the exercise stress test first. Since exercise makes your heart pump harder and faster, an exercise stress test can reveal problems with blood flow within the heart. In exercise stress tests, the heart rhythm, blood pressure, and breathing are also monitored. So what are the indications of exercise stress testing? First, to diagnose coronary artery disease. Coronary arteries are the major blood vessels that supply the heart with blood, oxygen, and nutrients. Coronary artery disease develops when these arteries become damaged or diseased, usually due to a buildup of deposits containing cholesterol and other substances. It can also diagnose heart rhythm problems. Heart arrhythmias occur when the electrical impulses that coordinate the heart rhythm don't function properly, causing the heart to beat too fast, too slowly, or irregularly. If the patient has been diagnosed with a heart condition, an exercise stress test can help the doctor find out how well treatment is working. It may also be used to help establish the treatment plan for the patient by showing how much exercise the heart can handle. The doctor may also use stress tests to help determine the timing of cardiac surgery, such as valve replacement. In some people with heart failure, stress test results may help the doctor determine whether they need a heart transplant or other advanced therapies. A stress test is generally safe and complications are rare. But as with any medical procedure, there is a risk of complications that may include the following. First, blood pressure may drop during or immediately after exercise, possibly causing the patient to feel dizzy or faint. The problem should go away after the patient stops exercising. Arrhythmias brought on by exercise stress tests usually go away soon after the patient stops exercising. Although exceedingly rare, it's possible that an exercise stress test could cause a heart attack. Exercise stress testing is not recommended among patients with acute myocardial infarction that happen within 2 days, those with high risk of unstable angina on pre-test probability, those with uncontrolled cardiac arrhythmias, those with symptomatic aortic stenosis. In aortic valve stenosis, symptoms develop when narrowing of valve is severe. The classic triad of symptoms are dyspnea, syncope, and angina. Those with pulmonary infarction, with acute myocarditis, and acute aortic dissection. Most individuals who present acute aortic dissection have history of open heart surgery. What are the safety precautions and equipment used in exercise stress testing? We have the treadmill, ECG machine, and blood pressure equipment. This equipment must be calibrated monthly. Exercise tests should be performed under the supervision of physician who has been trained to conduct exercise tests. This is the picture of TMT room where exercise stress testing is conducted. Picture of the treadmill with side and front rails and emergency stop button. Another picture of the emergency stop button placed in front of the treadmill. For the pre-test preparation, first, the doctor will ask some questions about medical history and how often and strenuously the patient exercises. This may help determine the amount of exercise that would be appropriate for the patient during the test. The doctor will also listen to the heart and lungs for any abnormalities that might affect the test results. So for the preparation for exercise testing, the subject should be instructed not to eat or smoke at least 2 hours prior to the test. The patient may also need to avoid caffeine the day before and the day of the test. Unusual physical exertion should be avoided. Specific questioning should determine which drugs are being taken. The labeled medications should be brought along so that medications can be identified and recorded. Because of a greater potential for cardiac events with the sudden cessation of blockers, they should not be automatically stopped prior to testing. But this is done so gradually under physician guidance only after consideration of the purpose of the test. During the test, a nurse or a technician will place sticky patches or the electrodes on the chest, legs, and arms. Some areas may need to be shaved to help them stick. The electrodes have wires connected to an electrocardiogram machine. This would record the electrical signals that trigger the heartbeats. A cuff on the arm checks on the blood pressure during the test. The patient may be asked also to breathe into a tube during the test to show how well they were able to breathe during exercise. Dynamic protocols most frequently are used to assess cardiovascular reserve, and those suitable for clinical testing should include a low-intensity warm-up phase. There are various protocols used in treadmill, at the same time bicycle stress testing. In healthy individuals, the standard Bruce protocol is normally used. Under Bruce protocol, among older individuals or those whose exercise capacity is limited by cardiac disease, the protocol can also be modified, particularly by 2-3 minute warm-up stages. The patient is asked to continue exercising until the heart rate has reached a set target or until the patient develops symptoms that don't allow the patient to continue. These signs and symptoms may include moderate to severe chest pain, shortness of breath, abnormally high or low blood pressure, abnormal heart rhythm, dizziness, fatigue, and changes in ECG. A positive test would show a flat or down-sloping depression of the ST segment, while a negative test suggests target heart rate, 85% of the maximal predicted heart for age and sex, is not achieved. Treadmill stress test has a sensitivity of 68% and specificity of 77%. So if the results are normal and the symptoms continue to worsen, the doctor might recommend a nuclear stress test or another test that includes an echocardiogram before and after exercise or medications to increase blood flow to the heart. These tests are more accurate and would provide more information about the heart function, but they are also more expensive. In pharmacologic stress testing, stress is induced using agents such as vasodilators. Examples are adenosine and diparidamol. These are not used in cases of asthma or COPD. Beta 2 agonists such as dobutamine can also be used. This drug, which when consumed makes the heart respond as it would if the person were exercising. Thus, it would allow a response to stress to be measured as well. These are the indications of pharmacologic stress testing. First, when the patients are unable to exercise adequately because of physical or psychological limitations. Another is when the chosen test cannot be performed readily with exercise. Another is the nuclear stress test, otherwise known as the myocardial perfusion imaging. If the initial symptoms persist or would get worse, the doctor may recommend a nuclear stress test. This would probably give a more detailed and accurate assessment of the patient's heart. The process is the same, but a dye is injected in the patient's arm that will show up the heart and blood flow on an image. It will also show the areas of the heart where blood is not flowing that may suggest blockage. This can be captured by an X-ray or single photon emission computer tomography or cardiac positron emission tomography. It is usually done on 2 separate days after rest and after injection of stress-stimulating drugs. A cardiologist will always be on hand during a test should an emergency arise. However, during the procedure, the medical technologist or the cardiology technologist is primarily responsible for patients' well-being. Here are some of the important things that the cardiology technologists are required to keep in mind when performing the procedure. First is to ensure that the patient has signed the forms, followed preparation guidelines, and the medical history was also provided. To also ensure that the patient would exercise as long as possible. Make sure also that the patient is well informed that they should tell if they experience any chest pain, dizziness, or other unusual symptoms. And to also monitor ECG continuously and prepared to stop the test immediately if any warning signs would appear.